Mr. Gomez is diagnosed with a right lower lobe pleural effusion. He is placed on diuretics and his imatinib is withheld. His symptoms of shortness of breath and lower extremity edema improve over the next 4 to 5 days. Mr. Gomez is seen 10 days later with complete resolution of the pleural effusion. The imatinib is restarted. Although rare, fluid retention is an adverse event related to imatinib therapy. It's important for oncology nurses to monitor for fluid retention events in patients with CML and to educate patients on the signs of fluid retention. 3 months after starting imatinib, Mr. Gomez's response to therapy is evaluated. A CBC reveals a white blood cell count of 25,000, hemoglobin of 11.9, and a platelet count of 550,000. It appears that he is not in a hematologic remission. A bone marrow biopsy is performed with cytogenetics, FISH, and qPCR to further evaluate his treatment response.
So, Mr. Gomez, how are you doing?
Well, I'm really anxious to know about my test results, and I want to know how well I'm responding to the therapy.
We do have your test results, and unfortunately you're not responding as well as we'd like you to. Given your difficulty with fluid retention, it may be difficult for you to tolerate a higher dosage of imatinib, but there are 2 other medications that are for patients that are no longer benefiting from imatinib, nilotinib and dasatinib. Nilotinib is less likely to cause fluid retention, and that would be the better choice for you.
The NP continues to educate Mr. Gomez on the role of secondary tyrosine kinase inhibitors, also known as TKIs, which include nilotinib and dasatinib. He was started on nilotinib, 400 milligrams orally twice daily. A thorough medication history should be obtained prior to starting nilotinib to identify whether the patient is taking any CYP3A4 inhibitors or inducers, as they can affect the serum concentration of the agent. Prior to Mr. Gomez initiating therapy with a secondary TKI, a baseline CBC, chemistry panel, and electrocardiogram are obtained. Monitoring of electrolytes is critical for patients receiving nilotinib due to the rare adverse event of QT prolongation. Hypokalemia and hypomagnesemia should be corrected to decrease the risk of QT prolongation prior to starting therapy and throughout the treatment trajectory. EKGs are obtained to monitor the QT interval at baseline, 7 days after starting therapy, and then periodically at the discretion of the healthcare provider. During the first month of therapy, he has no EKG or laboratory abnormalities. Mr. Gomez returns to the clinic for follow-up 4 weeks after starting the nilotinib.